Hello friends, in the sequence of ENT lectures, today we are going to discuss a very important topic and an interesting one. Perhaps uh, in any case of a class, previous classes we haven't discussed this. This is drug distribution in the nasal cavity, or how come different type of drugs are distributed in the nasal cavity. We will go through different sections in this video. This probably will go into two sections. This is the first part of the presentation, so let me expand it first. This topic is also very important as far as contemporary discussion of drug distribution is concerned, because the nasal cavity is suddenly become a hotspot in discovering how can we use the nasal cavity mucosa for the usage of drug delivery. We have got oral route of drug delivery, we have got parenteral route of delivery. About 60% of the drugs today we are using are of oral in nature. About 21% are parenteral or intravenous, you can say. About 2% of the drugs are only can be given through the nasal cavity. Some are transdermal also. So variety of drug deliveries portals we can use, but we can say that distribution of the drug, or giving the drug through the nasal cavity, is underused. And because such a vascular and a rich mucosa is available in the nasal cavity, frequently it is underused. And nowadays various vaccines, even antimicrobial agent, antiviral agents, various hormones, are even this insulin can be delivered through the nasal cavity. Anti-migrainous drugs, even contraceptive drugs can be introduced through the nasal cavity. So this area has now become a zone which is well debated in the ENT fraternity. How come we can use the nasal cavity for the use of drug distribution? Before impending into the discussion, let me take you to the histology of the nasal cavity epithelium. We have got three type of epithelium in the nasal cavity. About 90% of the epithelium is nothing but a pseudo stratified ciliated columnar epithelium. Pseudo stratified ciliated epithelium. This is a ciliary epithelium. These are microvilli are on the basement membrane. Underneath will be the lamina propria, and on top of it, each microvilli will have about 100 to 200 cilias are hair like structure which are formed by proteins. And these cilias has got they are immersed in two layers. Underneath will be the solution layer or sol layer, and top of it will be the gel layer. So any entrapped particle or microbe or foreign body particle or even drug is it's stuck on the gel layer of the epithelium, and is transported from anterior to posterior of the nasal cavity. So this is the nasal cavity. These are three turbinates. So the transportation of the drug and entrapped foreign body particles or bacteria or anything from anterior to posterior happens to be because purely of this movement of these cilia from anterior to posterior. They tends to beat in the gel layer. They have got a beating phase in which they beat and pushes the mucosa from anterior to posteriorly in a very high speed, about 5 mm per minute. The speed is there. So you can say that in about 25 minutes, 25 25 minutes, whole of the nasal cavity mucosa is renewed is secretions comes from the mucus secreting glands, also called as mucosal glands, also called as goblet cells. So these goblet cells constantly secretes this mucin, which is responsible for the moistness of the nasal cavity. And this constant beating of the cilias, this constant beating of the cilias from anterior to posterior in a synchronous manner, or even metachronous in some cases, leads to this transportation of these entrapped particle bacteria and drugs from anterior to posterior. So if you instill, sorry, any drug in anterior part of the nasal cavity, it will automatically distributed into the nasal cavity through the help of this mucociliary clearance mechanism. Mucociliary clearance mechanism. Every drug has got some time which it takes for the distribution, which is called as mucociliary clearance mechanism time. So if the patient is having any kind of a pathology like allergic rhinitis or chronic sinusitis, obviously the time taken from the distribution of the drug will be reduced. So mucociliary clearance mechanism affects directly on the nasal health. So it is reduced in pathologies like the edema of the nasal cavity when there are enough secretion in the nasal cavity, and when the nasal cavity is congested, much more secretions than the normal nasal cavity is there, then the mucociliary clearance mechanism is hampered, is impeded, and hence the drug distribution also be impeded. So before impending into the discussion about the distribution of certain drugs or various drugs into the nasal cavity, you have to have a good command or understanding of what a mucociliary clearance mechanism is. So this constant beating of these cilia into the respiratory epithelium, the most common epithelium is respiratory epithelium, or also called as pseudostratified ciliated columnar epithelium. In about 90% of the nasal cavity is this epithelium. About 3% is olfactory epithelium. Olfactory epithelium is in the area which is superior to the superior turbinate. We will delineate this area in next slides. About 3% will be the olfactory epithelium, which is much more whitish in nature, shiny in nature, much more thick in nature. And the olfactory neurons are directly suspended into the external environment in the olfactory epithelium. So this olfactory nerve is the only nerve, cranial nerve or nerve, which is exposed to the external environment, and it happens to be a chemical stimulated nerve, like the orbital cavity or in orbit. The eye is a chemoreceptors are present in the form of rods and cones, whereas in case of a ear, a mechanical stimulation is transformed into an electrical impulse. In case of a olfactory epithelium, it's a chemically stimulated a neuron rally, you can say. And in the this constant beating of the cilia is the single most important thing which is responsible for the nasal health. So in the beginning, let me say that there are three types of epithelium in the nasal cavity. 90% is respiratory epithelium, about 3% will be the olfactory epithelium, and rest of them, which is especially in the anterior part of the nasal cavity in the vestibule, will be the squamous epithelium. Squamous epithelium is nothing but a routinely keratinized epithelium which is present on your extremities, your hands and your feet, which is nothing but a keratinized squamous epithelium. So anterior part of the nasal cavity is lined by squamous epithelium, and this lateral wall especially is lined by respiratory epithelium, and roof of the nasal cavity is lined by olfactory epithelium, which is responsible for the olfaction. Olfaction is the sense of smell. How important this nasal mucociliary function is, we will name two giants of the rhinology. What is rhinology? Rhinology is the science of nasal cavity and its disorder. Stamberger and Kennedy. What Stamberger has to say about MCCM is, MCCM is the single most important factor in inflammatory disorder of the paranasal sinuses. So if the patient is having a routine or a normal mucociliary clearance beating or phenomena or happening, then the chances of inflammatory disorder in the nasal cavity and paranasal sinuses are much less. So you can say that in the Kennedy has said that mucociliary clearance mechanism must be addressed in every case of rhinosinusitis, and it directly reflects the nasal health. So much the importance of MCCCM is there. So in fact, when you measure this mucociliary clearance mechanism, you can measure it by some means like in case of a saccharine test, you can do a saccharine test. You can put the saccharine in anterior part of the nasal cavity, and the time taken from putting this saccharine on the anterior part of the nasal cavity to the time of the taste, the sweet taste arisal, is called as saccharine time. So this saccharine test is a simple, very simple test. You put some saccharine into the anterior part of the nasal cavity, and the time is measured from putting this saccharine in the nasal cavity to the arisal of the sweet taste by the subject. This is called as saccharine time or mucociliary clearance time. So every patient can have a mucociliary clearance time, which is reduced in case of a pathology. So you can say that this measurement of this mucociliary clearance mechanism is directly related to the nasal health, you can say. So this is a nutshell of the mucociliary clearance mechanism. So this is a lateral wall of the nasal cavity. This is, let me orient you first. This is the sphenoid sinus. This is the nasopharynx. This is fossa of Rosenmuller, which is a very important site for the carcinoma of the nasopharynx. This deep recess, which is present in the posterolateral wall, is called as fossa of Rosenmuller. This groove is called as fossa of Rosenmuller. Just anterior to it will be the opening of the Eustachian tube. And this tube is covered with some cartilaginous prominence, which is called as torus tuberous. And in case of a adenoid, the site of origin will be the roof of the nasal cavity, and it fills the nasal cavity and blocks the eustachian tube also, and the child can have a secretory otitis media. So this is nasopharynx, the anterior part of the nasal cavity. This is posterior part of the nasal cavity. Posterior part of the nasal cavity is continued with the nasopharynx through this opening. This is called as coana, you can say. And the plural is coani. Coani. A-E. Coani. Coani is plural of the coina. Coina is nothing but the continuation of the nasal cavity into the nasopharynx. This is coina. This part is coina. And these are three turbinate. This is inferior turbinate, which is embryologically different from middle turbinate and superior turbinate. So the area superior to the superior turbinate, which is ethmoidal area, the roof of the nasal cavity, or anterior cranial fossa, or cribriform plate, you can see. This is nothing but a cribriform plate. So this area is related to olfactory mucosa. Olfactory mucosa is a chemically stimulated neural impulse, and it is about 3% of the all nasal cavity epithelium. So this epithelium in the lateral wall is nothing but a respiratory epithelium. This part, anterior part, is a squamous epithelium, and this roof area is lined by olfactory mucosa. I am stressing upon these three different epithelium because of the fact that drug distribution through this respiratory epithelium is totally different from this drug absorbed through the olfactory mucosa. So you have to understand this point, that the drug which is absorbed through the respiratory epithelium will go into the systemic circulation, then it will go to the CSF formation through the choroid plexus, then it will appear into the CSF. It will take some time, about half an hour to 2 or 3 hours, even depending upon the size of the drug particle you are using, depending upon the lipophilicity or aqueous behavior of the drug, nature of the drug. either it is a powder based drug, or it's a oil based drug, or it's a aqueous based drug. What is the size of the particle available, which is the technique you are using, which is the instrument you are using, depending upon it, it will appear in the systemic circulation. Whereas the drug which is absorbed through the olfactory mucosa directly appears into the CSF, directly appears into the CSF. I will explore this point in later slides, I can assure you. But on the anatomical consideration, this is olfactory area, this is sphenoid sinus, this is sphenoid sinus. Roof of the sphenoid sinus is nothing but the pituitary gland. Pituitary gland is present in a fossa, which is called as sella turcica. So the roof of the sphenoid sinus is nothing but the lined by the anteriorly by the cavernous sinus, posteriorly by the this pituitary gland. Pituitary gland. This is the vasculature of the nasal cavity. You can see. So this is the skull base. So olfactory fossa, which is having olfactory epithelium, through which directly the drugs are available, made available to the CSF or drained into the CSF, is this area. This is anterior skull base. Actually, this is anterior cranial fossa, which is lined anteriorly by the frontal sinus. Posteriorly, it is lined by the greater wing of the sphenoid. Greater wing of the sphenoid. This is frontal plate, and this is supposed to be the middle cranial fossa, which is lined anteriorly by the greater wing of the sphenoid and posteriorly by the petrous ridge. Petrous ridge is the part of the bone in which the middle ear and the internal ear is housed or present, you can say. This is nothing but the foramen rotundum. Foramen rotundum. What are the structures which passes through foramen rotundum? You can ask for yourself and you can answer me after this. Let me take you to the next section. This will be the jugular foramen, foramen through which jugular vein passes. This is foramen magnum. This is clivus. Clivus is the bony junction of the sphenoid bone. This is sphenoid bone, and the occipital bone is called as clivus. So this anterior cranial fossa has a floor formed by the cribriform plate. Cribriform plate is a sieve-like structure, a multiple perforation, about 20 perforation in the ethmoid roof. Give me a minute actually. हेलो सर, मैं क्लास ले रहा हूँ, 10 मिनट में करता हूँ. ओके. So this cribriform plate is nothing but a multiple perforation, about 20 perforation available for the transmission of olfactory neurons. Okay. Actually, there is a technical glitch over there. We will continue the lecture in the next class. Probably it will disconnect. Some kind of a network problem is there. So we will discuss drug distribution. Actually, we have now discussed the anatomical portion of the drug distribution. We will discuss the actual drug distribution. How come this olfactory fossa takes part in the drug distribution in the next class. Please subscribe my YouTube channel also for new videos. Thank you very much for watching this.